Hello everyone, my name is Nagehan Ayakta and I'm a second-year medical student at the Stanford University School of Medicine. Today I will be talking about the opioid training surgeons receive. So surgeons are among the top prescribers of opioids, and studies have shown that there's a huge variation in the amounts they prescribe, as well as a tendency to overprescribe. Other studies have shown that 6 to 10% of patients actually develop new persistent opioid use following legitimate prescriptions for common surgeries. However, there's minimal research investigating how surgeons learn to prescribe in the first place. So the aim of our study was to determine the actual training as well as the perceived training needs of surgical residents and attendings when it comes to prescribing opioids. To do this, we conducted a qualitative study consisting of semi-structured interviews as well as a survey. We recruited 20 general surgery residents as well as 21 general surgery faculty. And we used an integrated method of analysis to look at our data. First, we applied deductive codes based on the theoretical framework of unintended prolonged opioid use, which is a framework that explains how primary care physicians prescribe opioids as well as the factors that affect them. And then we use inductive subcodes to pull out themes that are relevant specifically to surgeons. So our first finding was that surgeons lack formal training. Only 15% of our participants reported having any type of formal training. The interns specifically talked about intern boot camp as a formal training, but as this participant mentioned, they learned how to write a prescription properly, not how much to prescribe. And then attendings, on the other hand, mentioned having CME training. But this was in the early 2000s when they were told that they were under-treating pain and encouraged to give more opioid prescriptions. Our second finding was that in order to compensate for this lack of training, a lot of our participants utilized informal methods of learning. The first one being using external resources such as scientific articles looking for guidelines for evidence-based prescribing, as well as the trial and error of learning. So this is just learning on the job, noticing trends of what works and what doesn't work for their patients. In addition, they talked about another informal method of training being learning from the people around them, specifically the chief residents as well as the consulting pain teams. However, one thing that we noticed was missing was a communication between residents and attendings. The residents talked about a lack of guidance from them and rarely having any discussions of what to prescribe. And the attendings corroborated this, saying that they wanted to leave some autonomy for the residents and they didn't want to seem too rigid about it. Lastly, when asked whether they would want formal training, a lot of them had a desire for it. And what they wanted were specific guidelines telling them how much to prescribe for each surgery. They wanted it in the form of grand rounds so that residents and attendings can be in the same room together discussing. Some individuals did mention online modules, while others thought that this would be too burdensome and not effective enough. They also wanted this training to come early in their intern year so that before they form their prescribing habits, they can gain this information as a guide. And lastly, when asked who should deliver this information, some individuals thought it should be surgeons as they felt like surgeons knew their patients the best, while others thought it should be pain specialists as they deal with pain on a day-to-day basis. So when we put all this information together, we created a conceptual framework trying to describe how surgeons learn to prescribe. Initially, there's a lack of formal training and a feeling of helplessness, not knowing what to do. So in return, they reach out to external resources, the people around them, as well as just learning on the job. And putting all of this together leads to non-standardized prescribing across a cohort of physicians. And we believe that this cycle tends to perpetuate itself as new interns coming, looking to their environment to learn how to prescribe. So overall, we believe instituting formal training would help break this cycle and lead to more evidence-based prescribing by all surgeons. Of course, with any study, our study had limitations, including generalizability, as this was at a single institution, as well as possible participant and interpretation bias. In conclusion, we believe that this cycle is really worrisome, considering that over a third of all prescriptions written by surgeons are opioids. It's typically the junior residents who have the least amount of practical experience prescribing, and then they tend to solely rely on opioids for pain management. And lastly, that our patients can actually develop new persistent use after legitimate prescriptions. So we believe instituting guidelines as well as formal training early in residency will help lead to more evidence-based prescribing and better prescribing habits. And since this study, our institution at Stanford has actually instituted a training program led by a national pain expert for our medical students, as well as a prescribing guideline for our residents. So I'd like to thank my team as well as the funding that I've received from Stanford. Thank you so much.